Good morning. It's my privilege to introduce you to Dr. Pilar Osorio, Professor of Law and Bioethics at the University of Wisconsin and Bioethics Scholar in Residence at the Morgridge Institute for Research. Dr. Osorio's work is fascinating because it's positioned at the intersection of many different subfields. First, she has experience as a practicing scientist. She earned a Bachelor of Science degree in biology from Stanford before pursuing a PhD there in microbiology and immunology. As you might suspect, her research work resulted in the publication of scores of peer-reviewed scholarly articles, including many that focus on genomic sequencing, genomic testing, and attempts to understand the role of factors such as race and socioeconomic status in the big data sets that are frequently used to reach conclusions about entire populations. From a clinical point of view, she is interested in questions of data and informatics, and particularly in studying the ways in which big data can improve health outcomes. Related to this interest, however, her work often explores the role that big data plays in perpetuating, as she puts it, pernicious social inequalities. She received her Juris Doctorate from the University of California at Berkeley, and as a lawyer and bioethicist, she is deeply concerned with the sorts of ethical questions that arise when using big data in a diagnostic context, in medical research, and in the evaluation of treatments. Her work also embraces regulatory and public policy questions, and she's focused on the way that big data can help us implement healthcare policies that promote substantive, distributive, and procedural justice. Finally, she's both an educator and a public scholar. She co-directs the University of Wisconsin's dual degree program in law and neuroscience, and you may be familiar with her from an appearance she made on the PBS documentary, Race, The Power of an Illusion. So although this conference is virtual, I hope you'll join me in welcoming Dr. Pilar Osorio.
Hello, I'm Pilar Osorio, a professor of law and bioethics at the University of Wisconsin at Madison and the ethics scholar at the Morgridge Institute for Research. It's a pleasure to participate in the Nobel Conference, and I thank the organizers for inviting me. So today I'm going to talk about justice in machine learning for healthcare. And machine learning is a subset of artificial intelligence that involves teaching computers how to solve problems by learning from data. We say the machine is learning when it becomes better at its assigned task. And machine learning is related to the concept of big data because in order to learn, machines often need enormous amounts of data to analyze. And as they learn, they find patterns in data. Often these patterns are not discernible to the human eye or brain, and that's part of what makes machine learning valuable to us. When we say that the machine learns, what do we really mean by that? I used to wonder that all the time, like, what does it mean for a machine to learn? So what we mean is that people program an algorithm, and then that algorithm changes values in its programming, such as weights, probabilities, or parameters, until it arrives at a new, more functional algorithm, something we call a statistical model that fits the data. So in other words, machine learning algorithms are algorithms that make new algorithms. They have baby algorithms. They have offspring. So by developing a model that fits the data, the algorithm is able to answer the question that the programmer posed, and it's able to apply that model to new data to answer questions about the new data. And machine learning algorithms can range from mathematically quite simple constructs to very complicated mathematical constructs. But in a product, whether we're talking about a medical device or a smart refrigerator, there are several different machine-learned models that are usually incorporated into such a product, along with other programming, all operating in concert to make that product functional. So that's all I'm going to say about the technology of machine learning. There are other people who are better suited than I am to explain the details of the technology, and I think some of them have spoken before me. What I'm interested in is how the technology affects justice in the healthcare system. Now, of course, even when we focus just on the healthcare system and not on health more broadly, justice is an enormous topic to which people devote lifetimes. I am particularly focusing on questions having to do with how the deployment of machine learning in healthcare can be done in ways that combat health disparities and invidious discrimination within healthcare systems rather than contribute to these problems. So for now, I'm not going to define health disparity or invidious discrimination. We'll talk more about that later. Suffice it to say that these are problems that currently exist and are very well documented within our healthcare system, or affecting our healthcare system. So a bit of an outline. I'm going to talk about how machine learning is being currently used in healthcare systems. I'm going to talk then about how it can go wrong, and wrong in ways that perpetuate or exacerbate healthcare injustice or even cause harm to patients. And finally, I'm going to talk about how it can go right, or how we can at least tilt the situation in ways that increase the probability that our machine learning will improve the justice of healthcare systems. So we start by talking about deployment of machine learning in healthcare. And, you know, these days, I at least hear a lot of comments about how machine learning, or more likely artificial intelligence, is transforming healthcare. So I think these claims are a bit hyperbolic, at least for now. But machine learned models are being used in a variety of ways throughout healthcare systems. And they're used by healthcare providers to help make diagnoses or prognoses, to help choose an appropriate treatment, or to help summarize and communicate the ever-increasing medical literature. Machine learning algorithms are also used by health system administrators to assess and possibly to improve the quality and efficiency of healthcare delivery. They're used by insurers, both public and private, to predict future expenditures and to help identify fraud. They're even used by regulators like the FDA. And as this article here points out in this PowerPoint, machine learning algorithms are used very widely in biomedical research that where people are trying to develop new interventions and therapies that would be implemented in the healthcare system. So across the whole system, broadly construed, people are using machine learning now. And some machine learning algorithms they meet the definition of a medical device. So some of them are standalone medical devices. So it's just the algorithm that is evaluated as a medical device. Some of them are integrated into other pieces of hardware. And so here is an example of a machine learning algorithm, a deep learning neural network that was regulated by the FDA as a medical device, which means that it receives some kind of pre-market review before it is authorized to be sold. The product is called IDXDR. It's the first device, algorithmic device, authorized for marketing that makes a screening decision all on its own. So it's to help people, to help identify people who have more than mild retinal disease, and particularly for patients with diabetes, right? And so IDXDR can be used by healthcare providers who are not eye specialists. They can take a photo of a person's eye, upload that, the algorithm analyzes it, and then gives a report back about whether or not this person with diabetes has more than mild retinal disease. And if they screen positive in that way, then the patient would be referred to an eye specialist for a more definitive diagnosis. So I think this is an example of what appears to be a successful and very helpful piece of software, machine learning, that is being implemented in healthcare systems. So for algorithms such as this that are medical devices, there's a governance node, the FDA, and we need to figure out more about what standards the agency should use when evaluating software, and in particular, how it can use its standards and its regulatory authority to help tilt outcomes in machine learning for healthcare towards justice, and help ensure that the use of these algorithms doesn't exacerbate health disparities or invidious discrimination. But for better or worse, Many machine learning algorithms used in healthcare don't meet the definition of a medical device, or Congress has otherwise exempted them from FDA oversight. So those algorithms are mostly unregulated, but they can be implemented in the health system. So our governance for these kinds of algorithms is going to have to focus on things like voluntary self-regulation for the data scientists and companies who develop these pieces of software, for self-regulation within healthcare systems. But also we might think about accrediting organizations that accredit hospitals and what standards they have or develop in relation to machine learning. So I've given you an example of, successful rollout, but not everything is quite so successful. So here's an example of an algorithm that was widely implemented in healthcare systems across the US. The purpose of this algorithm was to assign each patient a score that reflected the complexity of their health needs. Purportedly, the score, if the score indicated that a person had significant health needs, then the system would target extra care coordination and other additional resources to that person. Didn't quite work out fully that way. It's a good idea, but maybe not well executed. So Dr. Obermeyer, the first author of this paper, and his research team were really able to experiment with this algorithm and get under its hood, so to speak. And so they had access to the code, to the data used to develop the algorithm, to additional healthcare data, including, so they had specific patient data as well as the data used to develop the algorithm and data that they could test the algorithm on. What did they find? They found that when the algorithm assigned a score of, for instance, a score of 3 to two patients, if one of those patients was white and the other one was black, that when you looked at the underlying health data for those two patients, the black patient had significantly more diagnoses, more prescriptions, more test values that were outside of healthy ranges. In other words, the black patient with a score of 3 was actually sicker or had more complex health problems than the white patient with a score of 3. So what they determined was that if the black patients were being scored comparably to the white patients, that instead of 17.7% of black patients receiving additional resources for their health care, 46.5% of black patients would have received additional resources for their health care. How did this happen? It didn't happen because the people who developed or implemented the algorithm wanted to underserve black people. It happened because instead of using actual patient health data to assess the complexity and seriousness of people's health needs, the algorithm was trained on data having to do with how much money was spent on people's health care. So the developers felt that this was a pretty good proxy for the complexity and seriousness of somebody's health needs. And that it seems intuitively obvious that if more money is spent on my health care, it's because I have more health problems, right? But what those developers weren't aware of was the huge literature on health disparities in the United States, which shows that black patients in the United States have more barriers to getting into the healthcare system. They're more likely to be uninsured or underinsured, so they have worse health insurance and worse options for payment. When they do get into the healthcare system, they are less likely to receive guideline-recommended care. So for a variety of reasons, a black patient with certain health conditions and a comparable white patient with certain health conditions in the US, on average, we spend much more money on the white patient than the black patient. And so by using amount of money spent as a proxy for complexity of health needs, they really missed the boat. And they inscribed into this algorithm a social inequality with respect to access to quality health care between Black people and white people in the US, right? So this is the kind of problem that raises the concerns that I bring and inspires this talk. Or it's one of the kinds of problems. And these authors describe this algorithm as a racially biased algorithm. And so what do they mean by racially biased? One of the interesting things about doing ethics in the context of data science is that if you want to measure the fairness of an algorithm or the disparities in a data set, you need to be very concrete and clear about what notions of pernicious bias or discrimination or what notions of fairness you're using. You need to operationalize those notions, and there can be many different ideas of what is fair. So, for instance, Obermeyer and his colleagues, one of the definitions that they use is that there's bias if an algorithm scores people with the same health need or problem differently based on their social group identity, right? So that's one definition of a biased algorithm, and it allows you to measure certain things and make comparisons among algorithms and score them and assess them as more or less biased. Another way of thinking about whether an algorithm is biased is if it has systematically higher error rates for people from one or more social groups, right? And there are other ways of defining fairness or bias in an algorithm. So having published that paper in Science, Dr. Obermeyer and some of his colleagues were invited by many healthcare organizations and tech companies and even regulators and insurers to evaluate their algorithms. And what they found is that in healthcare settings, algorithmic bias is everywhere, influencing clinical care, the operations of health systems, and policy. So that's disturbing. And what we know from people in science and technology studies, such as Dr. Benjamin here, is that the fact that innovation in healthcare often goes hand in hand with inequality and unfair inequality. So the benefits of cutting-edge science and medicine go disproportionately to people who already monopolize resources. In other words, the rich get richer when we talk about rolling out new and cutting-edge technology in healthcare settings. So here I want to talk about a little bit more about how it happens that we encode bias into our algorithms. And I should say that this problem had been noticed outside of the healthcare system, 5-6 years ago now. People started writing about it. And so many of us who were reading these books, so I've put up, the covers of a number of books that talk about how algorithms can encode bias, and bias not of a statistical sort, but pernicious discriminatory bias. Many of us who were reading these books were thinking, this has to be happening in healthcare too. We just don't have any concrete examples yet. But now we do have concrete examples such as the one I just showed you. So why does this happen? Assuming that it doesn't happen out of ill will, which I think it almost never happens out of ill will, right? Well, because algorithms learn on data. And the data often themselves encode or represent social inequalities. And this is particularly true because a lot of the data that algorithms for healthcare learn on isn't research data. So I have research data represented here as a kind of healthcare data. And it certainly is one kind of data used to train machine learning for healthcare, but it's probably one of the smaller contributors, really. There are many, many other kinds of data that arise out of everyday interactions between people and the healthcare system, between different parts of the healthcare system, or even, outside of the healthcare system. So data from wearable devices like Fitbits or Apple Watches might be used as some of the data for training machine learning for healthcare. There are other kinds of data that we don't typically think of as healthcare data or health-related that are also being used. For instance, there are algorithms that are trying to predict people's risk of heart disease that include among the data they analyze people's credit scores and other credit information. So we usually don't think of financial information as predictive of health states, but at least some data scientists are trying to see if those kinds of data are useful. So all of these, many of these kinds of data from many sources can be patterned by social inequality. They're also patterned by other factors besides social inequality. So the algorithms can learn those patterns in the data, just like the algorithm that Obermeyer et al. Reported on. It learned a real pattern. The real pattern was that we spend less on Black people's healthcare, right? So algorithms can learn patterns that are in the data that are really there, but sometimes the way they learn those patterns and the way we structure our algorithm when it learns those patterns can result in the perpetuation of unequal and unfairly unequal healthcare. So when we talk about data issues, some of the issues have to do with the fact that the algorithm might be trained on data that don't represent the actual patient population, and so it learns a model that can't generalize well to the entire patient population. A recently reported example of that from the end of 2020 was a report of racial bias in pulse oximetry measurement. So, the pulse ox is a device that you stick on a person's finger, clamp it on there, and it measures the oxygenation level of a person's blood. Pulse ox is widely used in healthcare settings, and you can get home versions, but they looked at the medical device quality hospital use versions or inpatient use versions. So they're one of the most widely used medical devices for inpatient visits. And they're used to decide whether a person gets oxygen or how much oxygen they get. They're used to assess the overall sort of state of a person if they're in an operation and whether they might be having a problem or not. So pulse oxes are widely used, and it turns out that these people analyzed tens of thousands of patients and discovered that the algorithm that analyzes the sort of physical information from the pulse ox device, that algorithm turns out to have been mostly trained on white people, and it doesn't work very well to assess oxygenation in patients whose skin is darker. So this is particularly pertinent right now as we are in a COVID epidemic, because the fact that pulse ox does not work very well or as well for people with darker skin, what it means is that it overestimates how oxygenated they are. So we are less likely to give them oxygen when they actually need it. We don't start oxygen as soon as we probably should in some cases where people have darker skin. And right now in the COVID epidemic, this really matters because, of course, looking at the results of a pulse ox is one of the ways we know whether a person with COVID is having lung complications, and that very much affects the kind of treatment we need to give that person. So this paper really hit as another kind of bombshell in the medical community, right? And this is an example of lack of generalizability of an algorithm that was trained on a narrow slice of the patient population and didn't represent the patient population more broadly. And it turned out in that sometimes that doesn't matter and the algorithm will generalize anyway, but in this case, it didn't. So what kinds of ethical problems does that result in? Well, it can actually result in harm, not only injustice, but actual harm, because people might not be getting healthcare that they need, and we don't know that. In other cases, not the pulse ox case, but in other cases, they might be getting the wrong treatment because of the algorithm's ineffective operation for them. Also, though, with respect to justice, it can leave some patients without the benefit of machine learning. And if some people persistently and repeatedly are left without a health advantage, while other groups frequently receive health advantage, then that can constitute a moral wrong of systemic discrimination. So I often have researchers ask me, maybe not often, but I've definitely had a number of researchers ask me, you know, so if I don't have a very diverse data set, but I can train an algorithm on the data that I have, and that algorithm might really benefit people health-wise, how can that be a bad thing? Because isn't it a moral good to provide benefit? And yes, it is a moral good to provide benefit, but benefit's not the only moral consideration in our healthcare system. And so if we were sometimes providing moral good to one group and sometimes, or if we were sometimes providing medical benefit to one group and sometimes to another group, and it all kind of even out and everybody was getting their health needs attended to at least some of the time in a comparable way, then the fact that you can provide benefit to some people, that's fine, or potentially fine, ethically speaking. But if, as so often happens, we keep providing benefit to only one group and the same group, and that group is already the more advantaged group in society, that's when it's problematic. And I think this is problematic not just at the level of the individual data scientists making some decisions, but at the level of healthcare systems writ broadly. So you might be violating Rawls' difference principle, for instance, by creating inequality, and not inequality that benefits the least well-off, but inequality that benefits the most well-off. Also, there are theories of egalitarianism that really focus on how people ought to be treated impartially by governments and major institutions, that they ought to be treated with respect, and they ought not to be oppressed or dominated. And one might think that this view of egalitarianism was being violated by a situation in which algorithms repeatedly and commonly are beneficial for one social group and much less beneficial for other social groups, because you've created a situation where people might feel that they're not being treated with respect or not being treated impartially because their health and their medical problems are not being attended to when somebody else's are. You might also, by widening health disparities, you could widen health disparities. And health is something we value in and of itself. We like to feel good, but we also value it instrumentally because it helps us achieve many other life plans and goals. And it's also, at least in part, a positional good. That means if somebody has a lot more health than somebody else, the person with more health, all other things being equal, probably will have more opportunities and advantages in society. So health matters to me both because it matters intrinsically that I feel good and that I can, and it matters instrumentally because I can achieve my goals better if I have better health usually, or in many cases. But it also matters to me what my health is like in relation to other people's health, because my health in relation to other people's health might also influence whether I can achieve my life goals or plans. So I do think that if machine learning actually operates in a way that exacerbates health disparities or unfair inequalities, then there are a variety of reasons why we would consider that unjust. All right, so I was just talking about situations in which we have training data that is too narrow and not representative. But the other problem, or another problem, is that we can have training data that are representative, but that encode existing social inequalities and discrimination, and then the machine learning algorithm learns that invidious discrimination or learns stereotypes. So one example of that is probably the algorithm that Dr. Obermeyer analyzed, right? That algorithm learned the social inequality of paying less money for Black people's health. And it learned it in a way, and the algorithm was deployed in a way that that learning potentially perpetuated the very inequality that it had learned and could have widened health disparities. We don't actually know, but it's quite possible. Other examples of this problem are actually, from outside of the healthcare literature, but this is a well-known example, right? That Google search engine for years, up until probably the last few months, really, or last maybe year, if you searched for assistant or searched for CEO, assistants were overwhelmingly female, especially the earlier search results that you would get, like the first page search results. Overwhelmingly female, whereas CEOs were overwhelmingly or entirely male in the early search results. And as I said, this has changed very, very recently. This particular screen grab is from about, I think, 4 or 5 years ago. But I periodically rerun these searches just to see what comes up. And only very recently did we start to see that the algorithm is no longer reflecting the glass ceiling. So here you have a situation where, for instance, having all the top searches for CEO present white male pictures, that might be a relatively accurate representation of who are CEOs of major companies, at least in this country, because there is a glass ceiling, or there are glass ceilings. And so CEOs are a pretty white male bunch. But so then the question is, do we want the algorithm to basically learn prejudices, if you will, or stereotypes? Do we want the algorithm to learn stereotypes and represent those stereotypes back to people? Because there's a certain kind of feedback loop where a stereotype is self-fulfilling. And so by showing people images of CEOs that are always men, you might perpetuate this situation in which CEOs are always men. So I was happy to see this quote in a very recently published online book, which you can get for free, and I think this applies to the healthcare system, that even in the absence of something that's explicitly discriminatory, if the algorithm encodes stereotypes in various ways, and those stereotypes can be self-fulfilling, I think that's a problem. And part of the reason that is a problem is because it can, in some kind of feedback loop, affect people's health, right? So if there are stereotypes that, men don't talk to the doctor as much, or they don't talk about certain things, if we keep feeding that stereotype back to people, that may affect men's health, or perpetuate a less than optimal situation. And so what these data scientists were saying is, as we integrate machine learning into decision-making, we should be careful to ensure that machine learning doesn't become part of this stereotype feedback loop. And I think that's right. All right. So, and when we're talking about machines learning, sort of social inequalities, when we're talking about health data, those social inequalities create health disparities. And a lot of those health disparities are not caused by the healthcare system's operation itself. They're caused by larger issues in our society, like residential segregation, and the fact that Black, Indigenous, and people of color have overall less access to healthcare, and things like that. So here are some definitions of health disparity, right? That they're avoidable health differences in some aspect of health, like the incidence, prevalence, mortality, or burden of disease. And they are we're comparing populations and sort of health and populations. Another definition comes from Healthy People 2020, talks about health differences that are linked to social, economic, and environmental disadvantage, and health differences where we see that worse health in people who were historically, who have historically experienced a lot of discrimination or marginalization, which is a form of discrimination or oppression. So not every single inequality in health is necessarily an ethical problem. But a lot of health disparities are viewed as ethical problems, so they're viewed as injustices to the extent that disparities reflect inequality in group welfare overall or standing, and often they do, right? Because, you know, being poor, living in a neighborhood without good schools, with housing stock that is more dangerous, with access to jobs that are more dangerous, all of that is part of having lower welfare. And it also includes having perhaps worse health, right? So health disparities are viewed as injustice either to the extent that they reflect group inequality in welfare, or to the extent that they're correlated with other recognized social injustices, such as systemic racism. Also, I think to the extent that they're remediable. So, and by that I mean treatable or avoidable. And you'll notice that in the first definition that I presented in the slide, the previous slide here, it talked about avoidable health differences. So there are theorists of justice, luck egalitarians, who think that some sort of accidents of nature are injustices, but in many cases, and thinking about justice within healthcare systems, if a condition doesn't have a treatment or we don't have any intervention that would help to prevent it, the fact that somebody develops that condition or that it's more prevalent in some group of people than others, we might view that more as a misfortune than as an injustice. And it might be a tragedy, but not necessarily an injustice. And I think also many people, when they think of the ethical dimensions of health disparities, think that they're injustices when they're unfair because they are maybe undeserved, or they arise for reasons that are not the responsibility of the group whose health is poorer. And I actually have some reservations about using the concept of desert in the context of health at all, but health or health care. But I think these concepts do come into people's notions of what makes health disparities an ethical concern. So I'm going to skip a slide that just gives an example of how health disparities, so actual differences, average differences between groups in some health issue, whether it's a particular disease or medical condition or some aggregate measure of health. So those differences can be measured in various ways, and one way people have started thinking about it is sort of geographically and with neighborhood deprivation index, right? But however you're measuring health disparities and whichever ones you measure, for our purposes, I think the important point is that they pattern our health. They give different socially situated groups have on average different levels and degrees of health, whether we're talking about particular health problems or health overall. And so the data about health are patterned by social inequality. And machine learning can learn those patterns and sometimes perpetuate those patterns in ways that either perpetuate health disparities or even could exacerbate them. All right, so we've talked about disparities that are sort of caused by social inequality that might be entirely outside of the healthcare system, but there are also things that happen within healthcare systems that lead to health inequality or that actually reflect systemic racism or individual discriminatory practices, right? And in this regard, I would point people to an oldie but goodie, a report from what was then the Institute of Medicine, now the National Academy of Medicine, from 2003. That's why I call it an oldie. It's a goodie only in the sense that the findings of this report are still overwhelmingly valid. And that's unfortunate because what they looked at in this report was hundreds and hundreds of papers that examined healthcare across, here they were really looking at different racial groups mostly. Hundreds and hundreds of papers that looked at the kind of care people get once they are in the system. So setting aside barriers to accessing healthcare and ways that healthcare is paid for, once somebody is actually getting healthcare, what quality of healthcare do they get? And they found numerous instances, and this has been well documented with a large literature that I can't review here, but numerous instances in which Black, Indigenous, and other people of color receive less good health care than white people. And just a couple of examples, right, that Black Americans are, to this day, less likely to receive guideline-recommended care for heart failure, stroke, and pain management, right? You do not want to receive your health care in the Indian Health Service where you receive lower quality care by almost any and every metric that anybody has applied. And there are numerous government documents or government reports documenting this. Gender affects the kind of healthcare one gets. And there are some diagnoses, such as diagnoses that have to do with heart disease or other heart problems, where a certain disease is associated with a gender, and heart problems are still in the public's mind, and it turns out in the mind of many healthcare providers, associated with men. And so women's heart problems are underdiagnosed, not treated according to guidelines, and this is a problem we've known for over 20 years, and still it persists. So these are just kinds of health disparities that pattern the health data that an algorithm might learn on. And if it learns those disparities, that might be a good thing because it might allow us to respond appropriately to real differences in health, or it might reflect, it might be learning basically bad medicine, right? And so that's what we don't want it to learn. We don't want algorithms to learn that, well, women don't really have heart disease, because that's not true, right? Heart disease is the leading cause of death for women past menopause, basically. But, you know, people still don't understand that, and we don't want algorithms to incorporate the same ignorance that all of us are acting on every day. So there are other things that are not necessarily injustices or bad medicine that pattern healthcare data that algorithm writers need to be aware of. I'm not going to go into these details because they're, I think, maybe less relevant from my points about health disparities and a kind of discriminatory disparate treatment. So here, I think, is a very important point, which is that machine learning also goes wrong because of a wrong problem formulation. So what does that mean? It means that the people who design the algorithm ask it to solve the wrong problem. And so going back to this example of the algorithm that scores people, the complexity of people's health needs or health states, the people who designed that algorithm asked it to solve the wrong problem in the sense that they asked it to classify people based on how much money was spent on their health care and not based on actually their health as reflected in, for instance, their medical records, right? So the algorithm solved the problem they asked it to solve. They just asked it to solve the wrong problem. And that apparently is a widespread problem in machine learning for healthcare. So let's talk in our remaining time about what we can do. And I've talked a bit about, what the justice concerns are, so I'm not going to belabor these points. But I also want to say that I think understanding how to ameliorate potential pernicious bias in health algorithms is more difficult than it is when we're talking about healthcare. It's more difficult to understand when an inequality that we see reflects pernicious bias versus an actual difference in health that we should be responding to. So we have patterns in health data that reflect, the isms, the racism, sexism, whatever, in healthcare systems, and we don't want the algorithm to learn and reproduce that. But we have other things that pattern the data, and sometimes it would be valuable for the algorithm to learn those patterns. And so just an example here, here's an algorithm that was trained on a very diverse set of data, and it was able to do better than human doctors at looking at X-rays of people's knees and predicting the amount of pain that person would report experience based on the pathology of the knee. So it was particularly good and particularly better than humans at predicting when the patient was a racial minority, a person of lower income, or a less educated patient than average. So those are the patients that human doctors do poorly when they're predicting pain for those patients. And the algorithm did better because it was trained on a very diverse data set, and it was trained with considerations of potential pernicious bias in mind. And so that's what we want to see. We don't want algorithms to learn site-specific kinds of effects, but we might want them to learn some of the actual health impacts of social inequality, because if we can learn them appropriately, we can make those apparent, but also figure out how the healthcare system can treat people and respond to health disparities in ways that might actually ameliorate them, right? So you can learn those, the patterns in health that result from systemic injustices. There are ways that algorithms can be designed and trained that perpetuate those injustices, but there also are potentially ways that algorithms can be designed and trained to help ameliorate those injustices. So, in thinking about amelioration, health systems should be incentivized, I think, by, for instance, accrediting organizations to use algorithms that are well studied before they're deployed. We actually need to do the kinds of experiments that Obermeyer and his colleagues are doing. And many other people are starting to do that, but it's relatively recent. So we need to incentivize health systems to focus on how well an algorithm has been studied, because it's not something that they typically focus on. We need to develop methods for assessing algorithm fairness, and that is being done. There's a lot of technical work as well as philosophical work being done in that area, and I'm really thrilled about that. We need to have federal funders step in here, because I think they can promote or fund the kinds of studies that are maybe a little more disinterested than having companies study their own algorithms, right? And they can actually fund the kinds of studies that produce publicly available knowledge about how to ameliorate bias and injustice in health-related machine learning. An important point, when machine learning is rolled out in healthcare settings, there should be some ongoing auditing of the deployed algorithms. And again, that incentive could be built into accrediting standards and metrics. Maybe we need better ways of setting our training and test data sets. So the data sets used to develop the machine learning, because that's not a really sexy thing for data scientists to do. But it's really important to have a better sense of how the data are patterned before we let the machine learn on it. Oopsie. Here is one of my bugaboos, and this is my penultimate slide, which is that so the FDA and other agencies need to help ensure that information about the appropriate use of an algorithm, its generalizability, its limitations, its indications and contraindications, if you will, that kind of information should be better communicated to users in healthcare systems. And then there needs to be some way to know that if that information is communicated, are people actually abiding by those limits? Are they using the algorithms appropriately? And so in some cases, the FDA could take some responsibility for this because they have labeling requirements. AHRQ might set some standards in this regard. But I really think actually communicating information about how to use algorithms appropriately is very important and very understudied. My last point is that all of the preceding recommendations, I think we will be more likely to achieve those goals if people work in multidisciplinary teams. So there's a fabulous paper out there recommending that data scientists read the literature on health disparities, and I think that's great, but it's a voluminous literature, and there are people who are experts in that field of health disparities. And so the better thing is to have data scientists work with those experts on health disparities, work with healthcare providers with domain expertise, work with medically underserved communities and philosophers, right? So very multi or transdisciplinary work, I think, is going to be necessary in order to help tilt us toward a situation where machine learning improves the justice of the healthcare system. Thank you for your time.
Welcome back. I'm here again with my colleague in the Department of Communication Studies, Philip Voigt, to have a little discussion about Professor Osorio's talk. Just a reminder, we're running a poll. If you go to pollev.com/Nobel57 or text Nobel57 to 22333, you can participate in our little poll, and Phil and I will talk about it in a little bit. So Phil, we're both humanists in discipline, and I'm wondering what were some of the key takeaways from her talk for you?
Well, I was really struck with her idea that algorithmic bias is everywhere, and some of the examples that she gave I thought were really interesting. The one that really set my hair on fire when I heard it was the whole idea about the pulse oximeter not correctly detecting dark pigmented skin and the oxygenation level. And so I think she gave a number of really, really fascinating examples, both of how algorithms can lead us to the wrong conclusion and how they can be kind of directed at solving the wrong problem. I thought that was really fascinating.
Yes, and in fact, as I was listening to the array of her examples, and particularly with respect to the data on which an algorithm is trained, it led me to ask a question. I wonder if you have a thought about this. Can we really say that a bias is not a pernicious bias if we routinely, in training an algorithm, forget to include entire swaths of the population? Yesterday we heard about cameras that didn't recognize different eye shapes, so that that someone kept being told that their photography subject had their eyes closed. that's just a kind of a silly example, but the examples you point to, for instance, a pulse oximeter that wasn't trained to acknowledge darker pigmented skin, seems sort of astonishing, right? Doesn't that start shading into perniciousness?
And it can be depressing on one level. I know in the talk that Dr. Rudin and Dr. Osorio did yesterday with the Gustavus students, they mentioned an example of where a hiring algorithm was systematically excluding people because they had Middle Eastern sounding names. And they went back and they interrogated that and said the algorithm actually was picking up on an underlying level of discrimination that was endemic. And once they found that, they were able to go back through the algorithm and kind of untrain it from doing that. So it is definitely a situation where it can be easy to get depressed and say, why are we still having this kind of systematic problem? So at the one level, I was really intrigued by the idea of regulation, and I was intrigued by the idea of going back through and kind of interrogating those data sets. And then the second thing that I thought was really interesting, and I can't remember how much they talked about it here versus in another talk that I saw, but is the idea of going back through and finding these inequalities in patient outcomes and then looking again at standards of care and kind of thinking again sharply about standards of care. But you're right, it is in one sense very frustrating that there are so many of these areas where they simply say, well, we don't have enough examples from this group, or if you have sporadic healthcare, for example. I know Dr. Osorio's work talks a lot about data cleansing and about the ability to get good data from certain populations. And it seems to me there's one set of problems that come with not having enough data in the algorithm, but then there's another set of problems with kind of asking ourselves the question, why aren't those patients in our system? Why aren't they included in the healthcare system frequently enough that we can get good data from those populations as well? So again, that may be a regulatory question, not as much a big data question, but I think it leads us in really interesting directions.
Yeah, that's a really important point, Phil. So one of the things that Dr. Osorio talked about was the fact that within healthcare, some of these algorithms, and this was fascinating, right? Like category construction. Some of these algorithms are actually categorized as medical devices. So I suppose the pulse oximeter would be an illustration of that, and others are not. So what's the significance of that distinction?
So again, if you think of that from a regulatory point of view, we have a very strict set of standards that we apply to things that are going to be marketed as medical devices. And I'm sure there's a degree to which this is true in all kinds of fields, right? If you think about where algorithmic devices are leading us, they could be in things like planes that we fly. I thought about the problem with the software in the Boeing 737 MAX. That was basically an algorithmic problem. And so if we started thinking about how to regulate these, either one agency that regulates all algorithms that are going to have kind of a high impact on people, or each individual agency, whether it be the National Highway Traffic Safety Administration, the Food and Drug Administration, the EPA, whatever the agency might be. But certainly she's really getting at there's a difference in how we regulate these by this rather arbitrary classification of whether we consider it a device. And increasingly, we're leaving it to industries to kind of self-regulate things that may be in that higher impact category. I thought that was fascinating.
Yeah, no kidding. So Phil, it looks like maybe in terms of time, we should hop over to the poll and take a look at what's going on with the poll for Dr. Osorio, Professor Osorio. So the question there was, before attending the conference, were you aware that some artificial intelligence and machine learning programs could learn biases based on their programming and the data on which they are trained? And I'm just curious to see, wow. So what do you notice there? Anything surprising about those data?
Wow, I think the audience was more aware of that as a problem than I was. I know I was really surprised. So good for our audience.
Yeah, no kidding. So the third choice is the second most likely. I've heard of it, but haven't thought about it much. But I've known this as a potential problem for a while now. Yeah, I think I'm with you, Phil, that I had a sense of it being a problem, but the ways in which it's being unfolded as a problem are, for me, really, really profound. So, for instance, boy, that just fell right out of my head. Sorry about that. I know that Wendy Chun, our last presenter, is going to invite us to think about why the perniciousness of bias in algorithms is actually an opportunity rather than simply a problem, which
Yes.
is a really interesting thought.